Good afternoon, everyone, and thank you very much, Professor Bilardo, for the kind introduction, and also to the organizing committee for inviting me. Well, actually, I have been offering first trimester screening for preeclampsia to my patients from October 2017, and I was asked to tell you my experience during all these years. And the first question that came to my mind was how we convinced our hospital manager to start offering this service. So we set up a meeting. He is a doctor, and we explained to him that well, how important preeclampsia was during pregnancy and the very bad figures that represents. But we also wanted to show that it's not only during pregnancy, but the rate of residual arteriolopathy was very much increased, especially in those cases when the onset of the disease had been very early in pregnancy, and how that arteriolopathy was related to posterior risks later in those mothers' lives, including the increasing risk of death. In Spain, there are 3,200 cases of preeclampsia per year, and these figures are global. We know that that is responsible of about 15–20% of maternal deaths and 15% of global prematurity. We also explained to him how preeclampsia was related to fetal and infant morbid mortality, including a fetal growth restriction, more pronounced and more severe the earlier the preeclampsia was developed, and the rate of perinatal death was also very much associated, especially due to preterm deliveries early on in pregnancy. And those preterm deliveries are something very serious. At 2 years of age, the rate of death and incapacity is about 20% for babies born at 22 to 31 weeks, and that figure was decreased to 2% when they were born from 32 to 34 weeks. And how all the rates of death, brain palsy, or decreased work capacity was lower with later gestational age, as I show in this table. He was very much convinced clinically, so he started talking business, as he says, and we showed how the cost per pregnancy from this European Europe was shown to be almost double when mothers developed preeclampsia as compared to uncomplicated pregnancies. And we also brought this study from the United States that shows the burden of preeclampsia for preeclampsia to the United States that costs about $2 billion per year. The ASPRE study that I'm sure you all know had just been published, and we showed to him how we could prevent up to 62% of preterm preeclampsia by only giving 150 milligrams of aspirin every night from 12 to 36 weeks to high-risk patients. And we told them that high risk meant screening positive from the FMF algorithm. We brought this diagram. If we were going to screen 1,000 pregnancies, knowing that the prevalence of preterm preeclampsia in Madrid region is 0.8%. That means 8 cases of preterm preeclampsia, detecting 3/4, we would detect 6, preventing 2/3, we would prevent 4. So we would need to screen 250 pregnancies to prevent 1 case of preterm preeclampsia. And we would only need to give aspirin to 25 patients for each prevented case of preterm preeclampsia. That means a 50% reduction. And the cost, what was the cost for that? Well, we would need to take proper history and mean arterial pressure, which we were already doing. That means €0, so no increase. To increase the time for our examination for our first trimester appointment, about 2 minutes after proper training for measuring artery pulsatility index, and the cost of adding PLGF to the first trimester bloods, that would be 10 20 euros at most if we were going to offer to all our population. And this slide is new. I'm bringing for you. This was published this year by the group of Professor Poon in Hong Kong. And well, they try to show here the number needed to screen from all those tests that we're familiar with: mammogram, colonoscopy, pap smear test. And well, it's just for you to see that the figures from the first trimester screen of preeclampsia are really good. And because to convince people they really need to see their own data, they don't want modeling, we reviewed all the births that had happened at my hospital the previous year. That was almost 2,500. We identified all the 57 cases that developed preeclampsia, and we looked at the days of admission from those cases delivered before 37 weeks, 34 and 32 weeks, and the number of days that they were admitted in intensive care unit and in the maternity ward. We calculated that each case of preeclampsia stayed a mean of 1.1 days in intensive care unit as compared to 0 in cases without preeclampsia, and cases with preeclampsia, preterm preeclampsia, had stayed 3.8 days in the maternity ward as compared to 2.2 in cases without preeclampsia. So with these figures, if we were going to screen 10,000 pregnancies, 1,000 would screen positive at 10% false positive screen positive rate. If all of them were going to go on aspirin treatment, aspirin would reduce from the 126 cases of preterm preeclampsia to only 58. So applying the cost of a day in EQ and intensive care unit, and in maternity ward, we could spend 8.3 euros per test to be cost neutral, and that is without taking into account long-term morbidity. But that's not the end of the story. It's also a baby, it's also an infant. And this very nice study, a secondary study from the ASPRI study, showed that the length of stay at the neonatal intensive care unit was reduced 1.4 days per baby that was on aspirin, mainly at the expense of those babies that were born very preterm, below 32 weeks. So 1.4 days reduction per baby that was receiving aspirin because of high risk. Again, bringing our numbers, that could mean that we would spend almost €500,000 in intensive care unit. And that would allow us to spend €186 per first trimester test. So numbers make absolute sense. And again, that's without taking into account long-term morbidity and mortality of those infants. But then he asked me why not use the NICE guidelines, and it was recommended in England. Simple, and he said cheaper, screening based on risk factors. And we were actually expecting that question because although our hospital is public and patients do not have to pay absolutely anything for their care, the hospital management is private, and at that time the company was British. So yeah, we had already prepared our documentation, and we explained to them that yes, screening by risk factors was a very simple method, but the detection rate was very low, only 40% at the same screen positive rate of 10%, and that it would not give our patients a personalized risk, and that would have consequences, as I'll show you later, right now. So this study, this pre-study from the Fetal Medicine Foundation, was not published yet, but fortunately I had the results available because, well, it's part of my working group. And they screened prospectively, but without giving results, 15,000 singleton pregnancies in England at 7 hospitals within the NHS. But the pregnancy care was by the NICE guidelines. So they proved that low detection rate of preterm preeclampsia of only 40%, but even more importantly, they also showed that from all the high-risk patients deriving from risk factors, only 1/4 were actually taking aspirin, despite they were supposed to be on that treatment. So either the patients were not convinced that they were high risk, or the doctors weren't, or more likely none of them, but they were not taking the so-called recommended medication. We explained how the competing risk approach from the Fetal Medicine Foundation works, and how the higher the risk, the earlier you are predicted to develop preeclampsia, and how aspirin would postpone that onset of the disease. How it works? Well, would determine the prior risk based on maternal factors. We would measure the biomarkers in arterial pressure, uterine artery pulsatility index, and placental growth factor in maternal serum, calculate months, and modify the prior risk to estimate the posterior risk, giving a personalized risk to each patient so that both doctors and patients would see their own risk and how likely it would be that they would develop preeclampsia at any desired gestation, at 37, at 34, at 32 weeks. It's something, if some new marker appeared in this time, we could easily implement in our algorithm, and it had multiple effects. So that was the comparison between screening from the NICE guidelines and the FMF algorithm, also from that SPRE study. And that was our aim. That was what we wanted to do, to applying a risk cutoff of 1 in 100, like in the ASPRE, to detect 90% of preeclampsias requiring delivery before 32 weeks, and 75% of the cases of preeclampsias requiring delivery due to the preeclampsia and the severity of the disease before 37 weeks. So we got cleared, and we started offering the screening. How did we do that? Well, that is the system that works at my hospital, but every setting is different. I'm just giving you ideas here. So we were taking first trimester bloods at 10 weeks. So we just pushed it a bit later, and we were booking them at 11 plus 3 to 12. In my region, patients have first trimester, the first appointment of their pregnancy with their community midwife at about 8-9 weeks. And then they come to the hospital to meet the obstetrician at 11 to 13 weeks. So they were booked at that gestational age for blood sampling for the first trimester bloods. At the end of the morning, all the samples were processed and the PLGF was processed. Then the patients were booked 5 days to 7 days later for the obstetric appointment. And before meeting the obstetrician, the auxiliary nurses were measuring the blood pressure. And then at the clinic, we included the measurement of the uterine arteries for screening of preeclampsia. And that is what we are still doing, and that works perfectly. So we can give the patient the results right at the end of their scan. We train all our staff, or the auxiliary nurses, on how to measure the mean arterial pressure, how important it was for the patient to be placed correctly, the arms supported at the level of the heart, and the back supported also in the chair. And well, we were asking them not to cross the legs. We changed our blood pressure devices to validated devices within pregnancy. We should let the woman rest for 5 minutes, and then to use the proper cuff size if they were thin or they were fat, just appropriately to their size. We were measuring the blood pressure twice in each arm, and we were taking the average of those measurements. We also trained the obstetricians to do uterine arteries. Well, I won't go through this. I invite you to review this course at www.fetalmedicine.org. That's absolutely free of charge, and it's much better than I could do it here directly at the Fetal Medicine Foundation website. So that's how we started in October 2017. Does it work? Well, it does. But I'm not going to give you the results from my little hospital. I'm going to give you the results from a multi-center study that we did in several hospitals in my country that we all started doing a first trimester screening of preeclampsia. And the setting, as I said, matters a lot, and you need to adapt your model to your hospital, to the place where you are. So some hospitals, some units were doing as we were doing, first the bloods and then the patient coming back a bit later. Some others were doing everything as a one-step clinic, either asking the patient to wait until the end of like 20 minutes or so after the appointments, or they were calling them with the results the day after. So it depends on your setting, how you will implement the screening. We learned how important quality control and monitoring was. And I'm showing you here how the different biomarkers distributions vary within centers. So it was very important to see and to monitor if one center was measuring the uterine arteries higher than expected, lower, etc. And this is an exercise that we should actually be doing for everything, starting by the first trimester combined test for Down syndrome. So we were doing monthly audits, and we were retraining our personnel, our staff, whenever needed. For example, that is my hospital. We were systematically overestimating the measurement of the blood pressure. And we realized that, well, the nurses were very excited with the new thing. And the moment the patient was coming into the clinic, they were taking it in to quickly measure their blood pressure. And probably that was not the correct way. So we told them that, and their correction was to start in underestimate. But then the balance came, and that is what I'm also showing here. That is the cumulative error, increasing constantly at the beginning, then decreasing, and the idea is in a straight line. And that is what happens afterwards. This sample, for example, is at the northwest of Spain, Coruña. And at the beginning they were right, but then they started to underestimate, and that was because they were measuring the blood pressure more times, and they were taking the lowest two measurements. Anyway, we gave them feedback, they corrected, and they started doing a straight line as expected. We also showed that on a monthly basis, at least, or if possible, we should update the factor for each, the correction factor for each center, as they do for so many things in our lab. For example, with the beta ECG and papillae, they need to correct every certain time. They need to calculate the adjustment factor, and they need to correct the moms by 8. Same for the uterine arteries. Some operators were underestimating, some others were overestimating, and by receiving feedback, they were constantly correcting their errors, human errors and nature errors. Nothing to be worried about. Just the moment you receive feedback, you look at yourself, at your performance, and you adjust that to become better each day, which is what all doctors and our healthcare personnel should do every day. So the performance of screening was excellent. The mean arterial pressure performed equally well alone, uterine artery, and also the serum PLGF performed as well as it performs in the FMF studies. The screening itself worked very, very well. Our rate of preterm preeclampsia was 0.7%. And after correcting for the amount of patients that were on aspirin for several reasons, it was a validation study. Sorry, I forgot to say, we were not implementing, we were not giving the results. That we are doing that now in the second part of this study, but at that time we were not giving aspirin. It was only the aspirin given by other reasons. So at the screen positive rate of 10%, the detection rate was about 65, and for screen positive rate of 20%, about 77. And you may say that that seems lower than for the Fetal Medicine Foundation studies. But the truth is that we have a much higher white Caucasian population. Almost all our patients, 98% of them, are of white racial origin, as compared to, I think, 85% in the FMF studies. So if we only took white patients from the FMF studies, you can see that the confidence intervals are completely overlapping and the figures are absolutely similar. And finally, the calibration of the model was as expected. The number of predicted cases matched the number of observed cases. So these dots match be very close to this blue line. So the calibration, our performance, our screening was doing as we wanted it to be. So to conclude, from clinical implementation of first trimester screening of preeclampsia, we know that first, it meets the criteria for population screening according to the WHO. It is cost effective, even if not accounting for long-term outcome. The organization, the logistics of the screening must be adjusted locally. So whatever I say may apply to my center, but not to yours. So you need to sit and think through it and apply the best model, the best logistics. It needs for continuous quality control and monitoring. And I believe all laboratories offering a PLDF may help you with the MOM calculation and this CUSUM and these nice figures I was giving to you. And if you do it well, if you monitor, if you control, it will have a similar performance as is as expected. Now we are in the second phase of our study. We already validated in 10,000 pregnancies. The results are ahead of published. You will see them soon. And the second cohort, we have 10,000 patients where we will provide prospective screening results and aspirin treatment. We have already screened 3,000 pregnancies. The uptake is extremely high. It's above 95% in all centers. We are 10 units participating now. And well, what we've learned so far is that women are compliant because fortunately in Spain, everything is centralized and we can check how many boxes of our medication the patient retrieves from the pharmacy. And for now, we're monitoring compliance, and that is always above 80%. So I encourage you to talk to your management and to start implementing first trimester screening of preeclampsia. Thank you very much.
Thank you very much to Thermo Fisher Scientific for hosting this very interesting presentation, and thank you to you, Mar, for this very, very elegant exposition of your results. I have a couple of questions for you. The first one is in your calculation of cost. You also alluded to it, but you didn't include the long-term costs that a fetus is born too early and with growth restriction or after a preeclampsia in the mother will face, because we know that this group of individuals will have a much higher chance of cardiovascular problems, diabetes in later life. So this is one of the aspect that I would like you to comment upon. And the second one is regarding really the implementation of this screening, which I really believe is extremely important, but it faces a lot of challenges. Well, first of all, we have to take into account the serum markers, and you alluded to all the problems of the serum markers, the mean arterial pressure, and we have to standardize very well this procedure, and then the measurement of the uterine arteries. In a way, is much more than what we requested in terms of accuracy at the time of the combined test. And the experience in my country is that sonographers, one way or another, had some difficulties in grasping the technique of the good NT measurement. And maybe that's why, although in some studies we had excellent results, nationwide the results were a little bit more disappointing. And my preliminary experience with preeclampsia screening in my country is also that especially measurement of the uterine artery is felt as very challenging. And because the screenings are performed not in hospitals but in decentralized clinics by sonographers, there is no one really to teach them to, let's say, that they can also ask for advice to. And I'm very much afraid that this will be very hard to implement with my enormous, let's say, disappointment. So are there some advice that you could give? And maybe we should also ask ultrasound companies to do their best to try to provide us with some instruments, as they did at that time with the semi-automatic measurement of DNT, to help us in our technique of measuring the uterine arteries. I'm sorry for asking so many questions, but I'm sure that, that you will be able to give us very enlightening answers. Thank you, Mar.
Thank you very much, Katia. Well, I don't know if it will be enlightening, but I will comment on my experience. So unfortunately, it is absolutely true that probably the costs from lifetime, the lifetime costs from those mothers and babies are far superior than anything we can calculate in short term. But the pity is that I sometimes feel that no one is interested in those. When I was discussing with my manager, and I was, as I was saying, providing these figures just to convince him that we could afford screening, whenever I started talking long term, he was like, "But that, how can you count that?" No, I cannot. That is the truth. And perhaps there should be a, I don't know, international, a collaborative initiative where we will follow those patients and we finally come with a study where we truly show, I don't know, long-term from the ASPRE study, long-term from, I think it's an effort that we're friends, we should consider doing some time. And probably we don't need 10 years or 20, or perhaps we do, but I'm sure that we will be able to see long-term cost for the infants in a much shorter period. That is for the first question. And for the second, it is very difficult at the beginning to go and tell anyone, whoever, that they are not measuring things properly. I found it very complicated when I returned from London and I just took everyone's NT measurements and I showed them that they were all underestimating it. And it was not, I mean, they were not happy with oversight to say that, no? So, but that was the very first time. Then no one wants to be told that they don't do things right. So a year later, I repeated the same exercise and the audit and they were fine. So and now it's we did the same for the uterine arteries. And the month I am delayed giving them the feedback, they tell me, Mar, why you didn't send us the uterines? Are they so good that we don't need to receive them anymore? So now it's something it's a routine process. They know that the first 5-10 days of every month, I send them their audits and they see how they're doing and then they're happy. And for example, I put myself as an example. I was measuring the uterines always automatically. what was my surprise when I received my audit, and I was underestimating so much. And I said, why am I underestimating? I took part in the ASPRE. I measured so many first trimester uterines. What is happening to me? So I started looking at it and I said, well, it's the calculate, the automatic thing that is not going as high as it should. So we adjusted the machine a little bit. And yeah, so I think it's giving feedback is not easy at the beginning. But I think what it becomes the routine, it becomes the same for everyone. Everyone receives that. Everyone is told how good or bad they are routinely. They take it better. And I think we appreciate. I think we are doctors, no, and we should do that. And if they are sonographers, I think they should also want to become better every day. But if doing that uterines is not a possibility and you think you will fail, to go perhaps with PLGF and mean arterial pressure alone and exclude uterines. I think it's a pity because they're so simple. But I don't know, probably also what you said to ask ultrasound companies to prepare hands-on workshops where one teacher can be with, I don't know, 4 or 5 people and be training for several hours. I think that could also work.
Or maybe to provide us with some anatomical referral points so that we will be sure that we are using the uterine artery on the right place. And then you measure manually and not automatically. I fully agree with you. Yeah. You have 2 questions from the audience. And the first one is from Marek, who asks, what is your clinic cutoff for a preeclampsia that you use to offer aspirin?
We use 150.
Okay, thank you very much.
Because for us it was 100 was very, we were screening positive like 8%, but our detection rate was lower because we're mostly Caucasian, white Caucasian. So we increased it.
And then the second question is about well, first of all, compliments for your excellent talk, and then the role of the ophthalmic artery Doppler. Do you envisage the possibility of also using information from this vessel to integrate in the algorithm?
I hope so. We received the Prof last week, so we are learning how to do that now. Hopefully next year we will tell you our experience. Yes, I think it's promising.
Okay, very good. So I think that this was a very interesting session, also with a lot of questions, and I would suggest that we can stop. And I thank you very, very much, Mar. And I'm sure that we will see each other very soon.
Very, very soon. Thank you. Thank you.
Bye-bye. Thank you.
Bye.
Thank you.